Okay, so in talking about HMOs and PPOs, those are two types of managed care. And what we mean by managed care is are attempts by organizations to reduce costs, bottom line. They want to reduce costs, still providing the proper care, but at economically conservative ways. What are some other ways of managing cares? A lot of times doctors and hospitals are merging together so that the doctor is in the hospital, so thus minimizing staff. Nonprofit hospitals are becoming for-profit hospitals. Green Bay has a for-profit hospital, one of the Aurora hospitals. It's the only for-profit Aurora hospital, and they do a lot of things that are very different there. They have a cafeteria that is fantastic. The cafeteria does 400 to 500 lunches a day for people that drive in just to eat and then they go home or go back to work. In the early 2000s, the cafeteria was voted in the top 10 restaurants in the city. Hospital cafeteria. They do that as marketing. They want people to come into the hospital, get used to coming to the hospital so that when they're ill, they're more likely to choose Aurora. Not a bad plan. But there's also something called integrated healthcare delivery. I'm not spelling it right. I think these pens will make it through this last lecture, and then I'm going to have to get rid of them. Integrated healthcare delivery. What does that mean? Well, integrated is the key. Integrated. Bringing together everything under one metaphorical roof. So let's picture an umbrella. Right? And this is why I became a nurse and not a graphic artist. An umbrella. A little poke there, right? In an integrated healthcare delivery, everything is in that umbrella. What do I mean by everything? I mean everything. So, let's think of the different types of healthcare services that could be brought together. We have primary care clinics. Hospitals. Acute rehab facilities. Long-term rehab facilities. Physical and occupational therapy. Visiting nurses associations. We're not done. Pharmacies. Skilled nursing facilities like nursing homes. Hospice. Preventive health clinics, like wellness clinics. So within this one umbrella, you have all of your types of care you'd ever need, except maybe not a funeral home. Primary care clinics, hospitals, acute rehab, pharmacies. Where do we see that? Well, in the eastern part of the state, Aurora does this very well. Aurora Healthcare System has all of these under the Aurora corporate umbrella. So what does that do? What does that do for you, the patient? Well, here's a big thing. It's so big I'm going to even write it down for you guys, right? Continuity of care. When all of your care is underneath one umbrella, you have good continuity of care. You see your primary care doctor, he puts or she puts your information in the computer system. If you see another doctor within Aurora, they have access to what your first doctor did. They have access to what pharmacies you go to and what PTOT said. And they have this umbrella of services that once you enter the Aurora system, they take care of you until the very end. And that's nice for you because you know the system, you know the people, you know the services you're going to be provided. It's seamless. It really is. In Manitowoc, my clinical transitions group is at Shady Lane Nursing Home. Shady Lane is not necessarily in a network with Holy Family Hospital, but they're very tightly connected. Connected, let's say that. One of Holy Family's doctors has her office in Shady Lane, so she has a clinic in the nursing home. The building itself offers assisted living, so people move into assisted living, and they see the doctor downstairs. When they no longer can handle assisted living, they go to the nursing home, which is just on the other side of the wall. They also have an acute rehab facility in that same building. So conceivably, a person could go to the hospital, go to the rehab center, realize they need help, so they go to assisted living. When they no longer can do that, they go to the nursing home. All in the same building. Integrated healthcare delivery. It is a method of putting under an umbrella all the services that a person would need. Think of Walmart. Think of Walmart being similar. You go to Walmart, you can get anything there. They've got food, they've got clothes, they've got electronics. They may have a tire center. They may have a gas station out there. They've got a pharmacy. They've got a photo center. A lot of times they have walk-in clinics within the building. They have eye clinics. They might have a restaurant. Like one of ours has Subways right in the building. You can get it, go right there. There's going to be a Redbox machine. So that is what we mean by integrated healthcare delivery. It does more though. It's more than just making it easier for the patient. It provides better costs for the facilities. Because if you see Dr. A and later on you see Dr. B can look in the records to see what your first doctor did. If the first doctor already drew blood and did an x-ray, the second doctor doesn't have to repeat it. And they can pull it out of the computer system and evaluate it. So they're going to reduce costs by reducing tests. They can assess, plan, implement, and coordinate much better. Again, with one system, with coordinated care, you move through the system very easily. Not everyone will use all the services. No, you won't. But it's there. It's there if needed. There's something else used for case management and managed care. It's called clinical pathways and disease management. Clinical pathways and disease management. Clinical pathways, they have similar purposes. Everything we're talking about today has essentially the same purpose: reduce costs. That really is bottom line why all of this is in place. We're not doing this necessarily because patients will have better outcomes, although they usually do when we use these systems. But they have better outcomes because people are acting in a standardized fashion. But what's really happening is we're reducing costs. We're reducing costs by getting them out of the hospitals quicker, preventing them from going in the hospitals, and keeping them healthier overall. So I guess in the big picture, There are better outcomes, but that's not the reason these are in place. The reason these are in place is cost containment. Clinical pathways. And disease management. Similar, but different, as in everything in life. A clinical pathway is also called a care map. That's the way I grew up knowing them. Care map. What does a map do? What does a map do? A map shows you how to get from point A to point B. It will generally give you ideas on how to get to point A, from point A to point B, the most efficiently too. A clinical pathway is a care map for a patient. It is a multidisciplinary approach to the best clinical practice for patients with specific diagnosis. So let's write that down. Care map is multidisciplinary. Providing best clinical practice, so best practices, for specific medical diagnosis. Specific medical diagnosis. They do not have care maps for everything. Where do we use care maps? For expensive problems. Heart attacks, diabetes, strokes, cancer. Things of that nature, there are care maps. Now, a care map is a remarkable document. They don't just randomly pop up. They are based on clinical guidelines that incorporate nationally accepted standards and, where am I? I lost that there for a second. I lost that for a second. I love my computer. Nationally accepted ways to handle specific diseases. So a care map or clinical pathway will look something like this. Admission. And it's going to list a number of tests. And then plus 12 hours, it's going to list other tests. Plus 24 hours, they'll have a benchmark. Should be walking. Plus 36 hours. Should be voiding. "48 hours. O2 at 2 liters a minute or less. Plus 72. Able to exercise to 7 mets. That's a lot. But we have labs, we have rehab, we have nursing, we have respiratory therapy, we have rehab. Multidisciplinary. And it's very precise. Let's say this is the treatment for a heart attack. Everybody who's admitted for a heart attack starts here. And then progresses down the path. What happens if the person can't walk? That's where the clinical pathway will branch off into their unique situation. Because if you admit 10 people with heart attacks, you're going to have 10 different conditions. Let's say one of those person weighs 600 pounds. Will they have a different progress than if I had a heart attack at 180? Probably. How about the heart attack who's also the person with the heart attack who's diabetic, or the person who had a history of a stroke, or you name the conditions. Every time you add a new diagnosis, you slightly change the path. You may bring in a second care map and kind of overlay them to make sure that you are treating everything correctly. Now, care maps are great. Care maps make sure that you never miss a test. It happens on a regular basis because these are standards of care that are tested. Care maps have one goal. Fast, safe discharge. Fast, safe discharge. By following the map, like any map you've ever used, is the shortest route to a fast, safe discharge. So, care maps are only used when a person is admitted to the hospital. That's it. They have specific timelines. It's multidisciplinary, so every approach, every discipline will be addressed in that care map. It's only for specific diagnoses. And it's based on best practices. The goal is fast, safe discharge. The goal is not necessarily, the primary goal is not better health. The primary goal is fast, safe discharge. The fact that these are based on best practices and that generally lead to good health is a good byproduct, but it's not the primary. So how is this different from disease management? Well, if care maps or clinical pathways are used inpatient and inpatient only, disease management is outpatient. Their one goal is not actually better health, but because that's the method. The goal is prevent admissions. How they do that is they keep the person healthier. Clinical pathway, their goal is to get the person home. How they do that is they get them healthy so they can go home. But the goal is to get the person home to save money. Keep them healthy so they don't get admitted to save money. In both ways, you are getting your patient healthy. You're getting them healthy with clinical pathways. You're keeping them healthy with disease management. But the reason for that is to save money. So, outpatient prevents admissions. Again, specific diagnoses. Generally, chronic conditions. Conditions that lead to frequent admissions. Generally controllable but not curable. And, like everything else, expensive. What are some common diseases managed? Diabetes, CHF, heart disease, asthma, emphysema, COPD, all those respiratory, pulmonary problems, heart disease, cancer. The big ones. Now, clinical pathways are multidisciplinary in approach. Disease management is generally nursing-based. And the way it works is not, we don't wait for the patient to get sick. In disease management, the nurses are proactive. The nurse will call the patient once a week, twice a week, once a day, whatever it takes. For the person with CHF, why are they calling? They're going to ask the person's weight. What's their diet? What's their activity level? Do they have edema? When you know that, you can tell from those 4 questions, are they having a problem or not? If their weight's stable, if they're eating a good low-sodium diet, if they're keeping active and moving around, and they have no edema, no CHF. I mean, they have CHF, but they're not symptomatic, keeping them out of the hospital. You might call this person once a week. If you see the weight start going up, you might start calling them every day. Same thing with all of these conditions. Asthma. Call the person. What's their peak flows? Are they using their medications? Are they being active? Are they symptomatic? Clinical care maps, inpatient. Disease management, outpatient. Care maps are designed to get a person home. Disease management are designed to keep the person home. And something that goes along with care maps is this little side note here. There's this thing called DRGs. Diagnostic related groupings. Diagnostic related groupings are used in the care map or the clinical pathway. Remember I told you when they weren't able to walk, they branched off? So here they were the MI, and here they branched off because the person was developing a DVT. There we go. They had a DVT, so now they can no longer walk. So now we add the DVT protocol. And you continue the MI protocol. But because of the DVT, they've added a new diagnosis to their list. Have you seen the discharge paperwork for some of these people and the list of diagnoses? The reason for that is every diagnosis adds a little bit of time allowed for the admission process. So when you have an MI, generally it's allowed 4 days for hospitalization or less. When you add a DVT, maybe now they're allowed 5 days. Now what do I mean by allowed 5 days? DRGs are used by insurance companies, by Medicare, Medicaid, insurance, and Medicare, Medicaid. Every DRG has a $ attached to them. So, and I don't know the $signs. I'm just going to pull some numbers at random, okay, just for the example. But let's say that heart attack is worth an MI equals $10,000. So, your patient is admitted to the hospital with an MI. The hospital knows that they will collect $10,000 because of that admission. but that's it. So they have an incentive to get that person home as quickly as possible. Now, generally, it's 4 days, and that's where the $10,000 is calculated. If they can get that person home in 3 days, they still get that $10,000. If the person stays 5 days, they still get that $10,000. Do you notice how that's very similar to the HMO that we were talking about before? Where the HMO is paid a specific dollar amount? Doesn't matter how many people are ill or not ill, they get the same dollar amount. Same thing here. So in this case, your patient has an MI. When he develops a DVT, oh, the DVT, that's worth another $5,000. And if he develops a fever, that's going to branch off again. Do another branch. That might be worth $500. So you see how every diagnosis adds to what can be collected? There is a limit to it eventually. At some point, what it adds to it is nothing. But that is why doctors and hospitals will list everything. Because Medicare, Medicaid, and insurance companies will look at that entire list and calculate what's it worth, what are we paying. So DRGs are not there to make sure that you get a good outcome. DRGs are there to standardize payments so that insurance companies and the government know exactly what they're going to pay for every specific condition. Every condition has a dollar sign. And they just add it up and write the check. Sounds kind of cold and brutal, but that's the way it is. And actually, there's nothing wrong with that because, again, when you have consistency, people can predict what's going on. This model of limiting payment is why we are getting good at getting people back to optimal or back to pre-admission levels. We might never optimize a person, but we will get them back to pre-admission. So, DRGs are designed to make sure that everybody knows what payment will happen. Clinical pathways disease management are designed to minimize costs. Clinical pathways by getting them home. Disease management by preventing them from being admitted or keeping them at home. Clinical pathways and disease management are both only used for the chronic, severe, expensive conditions. DRGs cover every condition. And if you next time you're working in a hospital, take a look at those. You'll see an entire list, and there's always a 3-digit number with a period, and then up to 2 more digits after that. Like a heart attack is 410. 410.0 is a specific type of heart attack. Might be anterior. 410.02 might be anterior with 1 blockage or whatever. I don't remember exactly the numbers, but that is how the companies know exactly what to pay because it's an exact description. It's not just a heart attack, but it's an anterior wall MI with 1 occlusion. It's specific. I'm going to come back to the next one. Ooh, these are fun lectures.